without further ado, I will introduce our speaker, who is Kerry Dowling, and she's a blood transfusion laboratory and phlebotomy manager at Southampton Hospital, and she's also the chair of the UK TLC, of which you will learn a bit more today. So over to you, Kerry.
Hello, my name's Kerry Dowling. I'm here to talk to you this afternoon about the UK TLC, what it is, why it exists and how it works and what we do. I'm just interested as the new chair to find out how our promotion of the UK TLC is going. So can I ask you to raise your hands if you've heard of the UK TLC before, using your raise your hand function? Okay, thank you. If you can lower your hands now, then we'll be able to tell if anybody actually would like to make a comment or discuss during the talk. Okay, so let's start with what is it? Well, on a very basic principle, it's a collaboration of professionals from the transfusion and scientific communities across the devolved nations. And that would be sort of my first introduction to what the UK TLC is. To understand a bit more about what it is, we need to understand why it was formed. So it was originally formed in 2006 in response to the data that we were capturing via the SHOT reporting. And what SHOT were finding was that 30 to 40% of the wrong blood events that were reported had originated within the hospital transfusion laboratories. So SHOT approached the IBMS to discuss between them and other relevant stakeholders working in transfusion what they could do about this and what the causes of the error rate were. And the UK TLC was launched from there in conjunction with our partners, the IBMS, SHOT, RCPAF, BBTS, UK NECOS and the MBTC across the devolved nations. So this data is taken from the latest SHOT report, the 2020 report. And what we see is that overall transfusion remains very safe, with a transfusion-related risk of death of 1 in 53,000 approximately, and a serious harm in 1 in 15,000 components issued in the UK. However, 81.6% of the SHOT reports are due to errors, and they're preventable errors, so things that we could have prevented from happening in the first place. And around 20% of those preventable errors are laboratory errors. They originated in the lab. And in the 2020 report, we saw 2 patient deaths, which were possibly related to lab delays. So we're all here to do the best for our patients, and we want to avoid these errors and potential deaths or poor outcomes happening. If you look at potential outcomes related to errors, the obvious things that spring to mind are patient death or patient harm. But actually, there's a lot more involved. There's a sort of a ripple effect to other things that occur when one of these incidents happen. So you've got distress to the family members of the patient that they've been through this scenario. You've got distress to the transfusion and the medical professionals involved, so our lab staff and the clinical people caring for the patients, and also potential reputational damage for your organisation when these things happen. So thinking about why, again, this is taken from this year's SHOT report, and this is where the errors occur. From 2016 to 2020, and you can see the colour table tells you what the various errors are. There's not really any strict pattern. They're occurring over all the processes that we're undertaking in the laboratory. So back to why again. At first look, a lot of these errors can be classified, or people classify them as human errors or failure to follow procedures. But actually what we need is good root cause analysis. And when you start doing that, what you find is they're usually not a human error. It's not as simple as someone's made a mistake. There are weaknesses in the system that lead to people making mistakes. There might be weaknesses in the QMS, so it might be your SOPs, procedures, training, weaknesses in your IT solutions. We have not great staff education, so groups like this are excellent for education. Staffing numbers not meeting the requirement, and human factors coming into all of this as well. So throughout COVID, human factors have really come to the forefront of things that are going on in people's lives, then affecting their work. If you're not careful from this sort of immediate human error, you can end up with a blame culture and decreased morale in your staffing, which further impacts on those errors. And again, if we don't act, we fail to learn from near-miss events or events of excellence. So action is needed. So if I was to redefine the UK TLC again, I would say it is a collaboration of UK transfusion laboratory professionals using evidence-based tools to reduce errors which occur in the transfusion laboratories and improve patient safety in the field of blood transfusion. This is a list of our collaborators. So all the key players are involved in the UK TLC. So we've got the IBMS and BBTS for education, the MHRA, our regulators, and UKAS, our accreditation body. RCPAF, the Royal College of Pathologists from a clinical point of view. We remain closely affiliated with SHOT, and they host our website, however we are neutral to the SHOT body. UKAS, the Ministry of Defence, and representation from transfusion laboratories across the devolved nations. So all the people that are involved in the transfusion process. So how did this start? In 2006, they started by running some workshops. So they gathered together transfusion professionals to look at why these errors might be occurring and what they might be able to do to help. And this was followed up by a series of surveys to gain evidence. And this is the evidence that they found during those surveys. And there's probably not a huge amount of change today in some of this, I think I would say. So 55% of transfusion laboratory staff lacked formal transfusion qualifications. 20% of the lead biomedical scientists were working on call or on shift, so they couldn't fulfill their lead roles because they were working on the bench. 6% of the laboratories had no staff with transfusion qualifications on a given working day. Knowledge and competency assessment was only achieved for 75% of laboratory staff within a 12-month period. Only 53% of staff laboratories had their ideal staffing levels formed by their capacity plans, which we'll talk about later. And 53% of those laboratories that did have ideal staffing levels frequently ran below that level on any given day. And 90% of labs had the facilities in place to perform electronic issue, but only 49% of those laboratories were actually doing so. So they took this information and decided that to try and help organisations reduce the errors that were occurring in blood transfusion, they would make some recommendations to provide a framework for education and training of lab staff and the use of information technology. So the first set of recommendations, as they were called at the time, were released in 2009. This was followed up by a set of surveys to monitor compliance. And the expectation from the UK TLC was that compliance would lead to a 50% reduction in the error rate that was reported to SHOT before. In reality, the 2012 SHOT report showed an error reduction of 16%. So great, the errors have reduced, but not to the level that UK TLC was hoping to achieve. So back to the drawing board, what next? In 2013, they ran a survey looking at the recommendations and why they may or may not have been implemented. And what they found was that there were a number of recommendations that had not been addressed by a significant number of laboratories, and that the number of IT errors had increased. So they looked for reasons why, and the frequent comment that they got in the surveys was that although the recommendations were excellent, management still saw them as recommendations and they carried no mandatory action requirements. They didn't carry enough weight to give laboratory managers some teeth to push these things through. So they went back to the drawing board, and in 2014 they redrafted and published the evidence-based standards rather than recommendations. And it was also agreed with MHRA and later UKAS that they would support those standards and they can use them as part of their inspectorate and accreditation processes. So the standards were given some teeth the MHRA or UKAS can raise findings in inspections related to the standards. So what else does the UK TLC do? So they've produced standards. They also run periodic surveys, and those surveys are to continue monitoring the effectiveness of the standards and compliance, and to provide evidence for future UK TLC projects. So we'll look at some of the surveys. We'll look at the two most recent ones that we're actually due to run a survey this year. So this is the 2019 survey, and these were the key findings. Staffing levels, unsurprisingly, probably for you all, remain a concern, with pressure to work extra hours to meet the demands of the service. A high level of inexperienced staff who require training, and they don't have enough adequate specialist staff support. And an increased overall level of vacancies and de-skilling potentially by recruiting at lower banding. So this is around the replacement of BMSs with associate practitioners. It has its place, but in some organisations it has caused some problems. Looking at vacancies as a whole for haematology, stroke, blood transfusion departments, the question was, what is your vacancy rate? And looking at it over the years, do you have vacancies? Yes, you can see that rate is going up. So we're not really getting on top of that. Blood transfusion laboratories have still got vacancies. And then a question about financial resources to support staff education. We all know how important education is. So the question is, have you seen any changes to the resources available? A huge amount had remained the same, a small number increased, but actually what's worrying are these areas where you have a decrease in funding or no funding available at all for education of our staff. The other survey that they ran in 2019 was called the Culture Survey. And this came from the fact that there were anecdotal reports included in shot and sabre reports that some of these worrying things were happening. And the things that we were worried about were disciplinary action against individuals. So there was some reporting to the MHRA that if a hospital had had a shot or sabre reportable incident, there was disciplinary action against individuals without full root cause analysis being carried out. So this is where we're heading into that sort of start of a blame culture that we were talking about earlier. There were some reports that audit or change data had been manipulated to make it look better, and that staff were being verbally criticised for actions that they may have taken or suggested in front of colleagues, and people were understandably distressed and upset by this. So these were the survey results. So 6 respondents were aware of themselves or a colleague being disciplined as a direct result of a quality incident, such as a sabre or shot reportable event. 20 had felt under pressure from line managers or senior staff to present an unrealistic impression of compliance. For example, the BCR submission or their information for where they were with audits, training and CAPA analysis. And they were aware of themselves or colleagues being affected by behavioural changes from pathology or trust management, i.e. they might not have investigated or reported the actual root cause of an incident due to pressure from people above them. And 37 respondents replied that staff were reluctant to work in transfusion, citing additional pressure over and above that of haematology or other pathology disciplines. So we're losing our staff because of the amount of pressure in transfusion, where perhaps another discipline doesn't have that same level of pressure or responsibility. So thinking about the bigger picture, we know that we don't have enough graduates coming into the profession. We know that we don't have enough skilled workforce, and we know that we have problems with retention. So if we've got this going on in the background as well, and this blame culture, that's only going to compound our problems further. And we'll talk a little bit about what we might do about that later. So other activities undertaken by the UK TLC. So we have a website, and on there are some tools to aid your compliance with the standards. We try to promote openness and communication between the key stakeholders, so all of those people that we were talking about earlier, and all of you who are working in transfusion laboratories, and offer forums for discussion. So an example from last year was the SHOP Meet the Experts breakfast group. We're having this activity now, and there will be future activities to enable forums for discussion. One of the tools that is available on the website is help with capacity planning. So this is something that you should have. It's a requirement under the Good Practice Guide. And what a capacity plan does is provide the staffing levels that are sufficient to cover your workload. And it should cover both in and out of working hours. And it includes everything from actually accepting samples and doing testing to implementation of an effective QMS. The capacity plan needs engagement and agreement at all levels, including senior management. So you should be able to report your capacity plan and any problems with it to senior management team and have support with that. And once the plan is in place, it's a really useful tool to monitor your compliance and identify any risks that might be coming up that you can escalate, or where you might need to increase your staffing numbers because you've got some new work coming in on board, or any of those sorts of things. So as I said, it is a requirement of the Good Practice Guide. It is a requirement under BSQR, and you may be asked to see it if the inspectorate come. It's also a question on the compliance report. So the organisation should have an adequate number of personnel with the necessary qualifications and experience. The management team has the responsibility to determine and provide adequate resources, and the responsibilities placed on any one person should not be so extensive as to prove a risk to the quality of the work that you're producing. So how do you do it? How do you do a capacity plan? You need to look at each individual role and the tasks that that individual role requires. So this is just a cutout, a small part of a blood bank manager's description, for example. You take the tasks, all the tasks that they need to do, and you work out how much time it takes to perform that task each day. So here, replying to emails, 5 hours, I think this is over a week. And then you can work out how much that is of a whole time equivalent. When you've got all your tasks, it will tell you how many whole time equivalents you need to successfully fulfill that role. And then you can build a matrix of how many staff are required at what levels to run your service, at what level and what time of day. So you'd probably have a core hours and an out of hours capacity plan. And you can see from this one, this is a senior role that it involves EQA, incident reporting, IT support, traceability, all of those things that we have to do every day that are just as important as sample testing. Once you have your capacity plan, you can then set up a way to monitor it. So this is an example from one of my colleagues where they monitor compliance by looking monthly, did they meet their capacity plan requirements? If you're not meeting your capacity plan requirements, you've got evidence then to escalate that. And you can escalate to the risk register and you can evidence business cases asking for more staff. So what does the UK TLC look like now today? So I've actually recently taken over. So I'm the new chair, as our former chair had retired, and we created a deputy chair post as well. So Jenny Davies, some of you may have heard her speak before, is our UK TLC deputy chair. We're currently updating the standards, so there will be a 2022 version. It's in draft at the moment and just has to go through the approval process before it will be released. We're looking to increase the profile, make people aware what the UK TLC is and that it's here to help you guys. Be setting up a Twitter page, attending educational events, and we have our website, and the website address is here in the slides. And we also have a new logo. So I think the first part of discussion for me is what else can the UK TLC do to help you? What would you like to see from us? What would help you in your current workplaces with the stresses that you're under? Please, you can put your thoughts in the chat, or you put your hand up if you want to speak.
So we've got 128 attendees with us today. It would be really interesting to hear some contributions to the discussion. So as Kerry said, if you don't have access to a microphone, do please put something in the chat, and I'm quite happy to read that out for you. But it would really be interesting to hear, you know, what else can the UK TLC do to help you as a biomedical scientist, and whatever grade you are at the moment, whether you're in a management role or whether you're working on the benches or both. It would be really interesting to hear from you. So, Kerry, we've got one comment in at the moment. Samantha says recommending good educational cases and perhaps examples of good root cause analysis.
So sorry, Danny, that was good educational. What was that? Sorry?
Yeah, so recommendations around good educational cases and perhaps examples of good root cause analysis.
Okay, so what should be coming out with the 2022 standards is an update on the expectation of the qualifications that you would have at various levels. So that exists now, but it's been explained in a clearer way. So that will give you a link to courses that you might be able to do that are transfusion related, to give you enough education to be at the various levels. So the agenda for change banding. So for example, there are the BBTS transfusion science and clinical transfusion courses. There are various courses that actually have CATS points attached to them. So there will be some lists of things that you can do as transfusion staff education wise. And the second part, Danny, was?
The second part was around examples of good root cause analysis.
Yeah, that's something I hadn't thought of, so that's interesting. We could probably work with Chris Robbie to put some examples of good root cause analysis on our website. I'll take that down as a note to take forward. So this is useful for us as well.
So we've had lots of comments since that comment, Kerry. Lots around how do we improve recruitment into the profession, and how do we improve retention. Some comments around difficulties with getting degrees and then later on getting the certificate of competence and becoming a registered BMS. I think that's a well-known challenge. Staff retention is coming up, similar to the root cause analysis request. Samples of good CAPAs.
Yep. So I can take that back. In terms of the having the right degree and IBMS registration, I think that's an ongoing thing for all of us that we've always reported back. So working closely with the IBMS, and I know there are some changes going on there, so watch the space, see what happens. Obviously there is a requirement that you have an appropriate degree to do this role, but I think more what I would like to see is supporting staff to gain the education they need to get their IBMS accreditation. So the question earlier on about what resource do you have to support education, I think that's really key, really important that we get organisations to grow their own, as it were, to invest in people that could be very good at the job and they just need that right degree or right set of top-ups or whatever it happens to be to gain their registration. And then retention's a very difficult one, isn't it? It's something that we all struggle with. And I think if we improved the conditions in the transfusion labs, so if we had the right number of people doing the job, that would take away a lot of the stress. So that's where your capacity plans come in, that you've got the right staffing levels and that you can evidence that to management, trust exec level. This is what we need. And then the blame culture. If we can move away from that sort of blame culture that's creeping in, so that people feel confident to do their job and not worried that they're going to be blamed for something that goes wrong. So they've got all the tools they need. They've got the correct procedures, processes in place to use, and that they are not going to be frightened when something does go wrong, because inevitably at some point these things do happen. International recruitment.
So lots and lots of comments coming in now. Apologies if we do miss your comment. Please feel free to put it in there again. I am trying to keep up with these. So there's a common theme occurring, Kerry, around some guidance on some of the quality aspects, some around CAPAs, around audits, around root cause analysis, and some resources to support colleagues in becoming more competent and confident in performing those tasks. An interesting one here from Tim. Could you mandate a national programme of training in competency?
I'm not sure that we would have the power to fully mandate a national programme, but we can make recommendations of what that maybe should look like. So one of the things the UK TLC does is also report into groups such as the MBTC. So those are things we can always take to them to say, look, as a community, we feel like this is what's needed. And there's a question there about international recruitment as well. So unfortunately, I don't have any update on international recruitment. Again, that's kind of outside of what we do. But I would approach the IBMS if you've got questions about, is the degree appropriate for registration in the UK? That's probably what that's referring to. I don't like shift. So I'm just reading this comment here from John. Recruitment and retention is a problem. Several staff has left because they don't like shift work, and it's hard to recruit qualified BMS staff or trainees who stay post registration. So I think again nationally that is a big problem, that you recruit someone as a trainee or an associate practitioner, put the time and effort into training them, and you get a great member of staff at the end of it, and then maybe they will leave, go somewhere else. Often we get people moving into London. So again, I think it's about making your workplace the best that you can. If you've got a good environment where you're working, maybe they're less likely to leave, and making the profession more recognised. So one of the comments that we get is, if you're a nurse, if you're a doctor, everybody knows what you do. But if you're a biomedical scientist, that's not very well known in the public domain. So there is work going on about promoting the biomedical scientist role and what that is. And I think we need to start at an early level as well, GCSE school age children, where they're starting to think, what do I want to do with my life? What career would I like to get into? That's the time to start making people aware that this is an option and what opportunities are available to them, to try and get them on the right pathway in the first place, so that they don't then end up in a position where they want to be a biomedical scientist, but they haven't done the appropriate degree. A comment from Gillian Clark here about Scotland having the integrated degree system, where they can complete their competencies on a lab placement. So we had the same thing in England and in other places as well, where they take a placement year out of their degree, do their portfolio and their verification, and then they're ready for registration once they finish their degree. And I would agree, these graduates are snapped up straight away. It's a very good route. Another good route, I think, is apprenticeships. If you can support apprenticeships, we're all paying into the levy as NHS organisations. So let's utilise that and support staff through the apprenticeship route, where again, they do their degree and they work and they come out at the end with their registration. So there's not a formal registration to be part of the UK TLC. So it's a group of professionals that are sort of invited in, usually from laboratory manager level upwards. Having said that, we do we invite people to join our meetings so that we can hear different views, and if anyone has a particular interest perhaps to join us at some point, or an idea, then I'd be really keen to hear it. What I'll do is get Danny to share my email address at the end, and then if anybody has any particular things they'd like to see from us, or a real interest in joining this sort of work, then if they could let me know. Okay, so we had some good discussion there. I actually only have sort of a summary now, and then a chance for you to ask any further questions you've got about the UK TLC at the end. So we are a collaborative group of professionals, and our aim is to improve blood transfusion lab safety and reduce errors. We're producing standards which are used by the inspectorate bodies and the accreditation bodies, so they do have some teeth. and you can have findings raised against your organisation if you're not complying with those standards. We collect evidence of compliance in areas of improvement, and we produce tools for BT professionals to aid compliance to those standards. And as I said, we remain very closely affiliated with SHOT, but a neutral group. So any further questions or anything that anybody would like to discuss? There's something there from Kundi about, oh, it's just moved, sorry. Trade union style collaboration. So that's not something for me that I would be able to answer, I'm afraid. I would encourage you all to be open with your employers in your own places of work, and where there are systemic problems, then have those discussions with your lab managers, with your team, because the only way that we resolve these things is by starting to talk about them and knowing that they exist. There's a comment from Oliver about the NHSBT courses. They are excellent courses. If you can get on them, I would strongly recommend them. They have some practical based, 2 levels, I believe, of practical based courses. And he's asking, is there any scope to expand those to a more formal qualification? Again, that's outside of my remit, but Danny, actually, you might want to take that to Ruth. I know they're working on that program now.
Absolutely, yeah. I can take that away, Oliver, and I can either come back to the group or come back to you directly, depending on the response. If it's worth sharing amongst the whole group, then absolutely, yeah, I can take that away, Kerry.
Yep. So there's a comment about virtual training groups. So this sort of event, the BMS education groups and others that are run by the regional transfusion committees throughout the UK, very, very good tools for education and learning. And I would encourage you to take part and maybe even do some teaching yourselves. It's great to hear from all our colleagues, not the same voices every time. Diane, will you be reviewing the standards of education? Are you referring to the IBMS standards there? As a group, if you are, we won't be reviewing the IBMS standards. We are reviewing our recommendations for education levels for transfusion laboratory scientists. How do other laboratories, so Carol Harvey, how do other laboratories record the mandatory 70 hours? Carol, are you talking about, so the UK TLC standards currently say that you should do 10 working days per year on the bench to maintain your competence. For example, if you're a senior member of staff and you don't work routinely on the bench. Is that the question that you're asking? Is there anyone here who has to record that information, and what different ways do you use to do it? So for myself, I have a spreadsheet of my Band 7 staff. So I can clearly see over a year that they've done their 10 days, and I record it in a spreadsheet. It's recorded in our roster as well. But there may be other ways of doing that. If anyone wants to share any ways that they record that. No.
Kerry, there's an interesting extension onto the question around the education standards, and that's around will the UK TLC make recommendations for minimum education standards for each banding or each grade of staff?
Yes, and Carol's come back with her answer to this. So the UK TLC breaks staffing down into agenda for change banding, because that's the common way of banding of pay grades now across the devolved nations, and it says at this level this is the education that we would expect for you. So I can't tell you exactly what it says yet because the new standard hasn't been released. It's similar to the current one. It's going through peer review at the moment, which is why I can't say exactly what it says, but it will then break that down into examples of how you might be able to achieve that. So one of the comments that we've had on the previous standards, again, is that, you know, they're great, but actually, how do you do this stuff in practice? So the aim for the 2022 standards is not only just to say this is the expectation, but also here is some examples of how you might want to do this. Does that answer your question? Yes, we will break it down by band and what the expected qualifications are. There's no huge surprises. Everything needs HCPC registration, and then various levels depending on what grade you're at, whether you're a specialist scientist, a advanced, or a band 5 newly qualified. There's also some guidance in there for the support worker level and how, as I said, how we might support these people to progress in the future. When will the standards be out? So they're currently for peer review and sign off. That process is kind of a bit of a how long is a piece of string process, unfortunately, so I can't give you a definite date, but I would hope within the next couple of months we'll be able to start releasing those, and looking to publish them in Transfusion Medicine where they were published before.
So there's a really interesting question from Fiona, Kerry, on an item that's probably becoming increasingly common. What about labs that are multidisciplinary, not just blood transfusion? With people on shifts, it can be very difficult to retain the correct staffing levels in blood transfusion. Is there any other experiences of this?
Yep, so I think, again, this is a common problem across multiple labs in the UK, and the standards refer to staff who are multidisciplinary and the expectation of training and competency for them. It is difficult. I can understand that it's difficult to maintain their competence when they're not working in transfusion all the time, but the standards give you some teeth as managers, as an expectation that these people will spend a significant amount of time in the routine blood transfusion lab maintaining their competencies, and will have the right level of education as well. Also covers a little bit about locum staff to say that we would have the same expectations for locums. Okay, have you picked anything else out there, Danny? Any more themes?
So there are lots and lots of comments, with you know, lots of them are around staffing, recruitment, and retention. So I've been trying to find a wider variation of topics. There's a question here from Joanna. It's quite a long one, so just bear with me. Personal problem from my small hospital. We are working night shifts in weeks, so 7 nights in a row. On nights, only one BMS covering haematology, blood transfusion and specimen reception. And the question is, would it be possible to state minimum staffing out of hours in hospitals with blood transfusion?
Okay, so I don't think that can come centrally because every hospital is different. Their workload is different. The way that they manage that workload through the night is different. But what should be happening is that the individual hospitals should be producing that capacity planning report. So they should be looking at what is it that needs to be done overnight? How long does that take? And therefore, do I have the right number of staff to deliver that service safely? And it might be that those tasks, one whole time equivalent is enough. But then again, it might not be. So I would advise that you go back to your lab manager and you can ask to see the capacity plan, or ask if they don't have one yet, what's the plan in getting that into place? Because not everyone, we're all very busy individuals, not everyone may have got their capacity plan in place yet, but they should be thinking about it, working on it.
Thank you. A different question now, Kerry, and it might be quite difficult for you to answer as being new in post as chair, but what has been the biggest challenge the UK TLC faces since its inception, and what is being done to address this?
Okay, so that is difficult for me, given that I've been in post for about 3 or 4 months. But from what I've learned from my colleagues, from what I've seen over time, I think the biggest challenge is probably the hospitals being able to adopt these things because of everything that's going on in the background, whether it be funding, whether it be lack of actual people to take these positions, means that you can have the best standards in the world, but they need to be practical and they need to be adoptable. And I think that's the biggest challenge for me going forward, certainly, is to produce something as a team that will help improve transfusion safety, but that is actually achievable.
Thank you. Does anybody else have any questions or any just points of discussion that you'd like to bring up? We do have a few minutes left. Apologies if we have missed your question. The comments have come in thick and fast, so it's been difficult to keep up with all of them. Question just coming in. Do capacity plans take individual needs and working processes into consideration?
When you say individual needs, Shabana, do you mean individual people? So it should take individual working process into consideration. So the process for your hospital, whatever that happens to be, not necessarily individuals' people's needs. I think that will be managed outside of the capacity plan. It would get incredibly complicated if you had to include that as well. I would say you need to be aware that certain individuals may have different requirements, but your capacity plan is a sort of a overarching, this is how many people I need to run this service safely.
Yeah, and we have a hand from Martin. So Martin, I'm hoping that means you want to unmute and ask your question. Please do so if you.
Yeah, it's just related to business continuity plans. I mean, we always have contingencies of going sort of manual, but for those where you might have neighbouring hospitals, the issues we come across is that, you know, no one has sort of compatible IT systems, and such that interoperability is, you know, not really that possible, not feasible. I was wondering, in your national surveys, how often do you come across this aspect?
So UK TLC hasn't specifically come across interoperability. There's probably one for the SHOT team and the IT experts. I think with the move towards networks, we might see that start to ease, because hopefully in our networks we will at least have compatible IT systems, but it's probably a while away yet. Yeah,
that's my thoughts as well.
Yeah. I think just to
thank you.
Just to expand on Kerry's answer there, Martin, you might be interested to know that the next time we meet next month, we will actually be looking at developments and advances in IT for blood transfusion laboratories. So that might be a really good session for you to come back to.
Oh, good, excellent.
Yeah, this is Julie Staves is talking, isn't she?
That's right. Yeah, really good speaker.
Yeah.
Brilliant, thank you.
Okay. Is that another Philippa? A hand up there?
Yes, so I just wanted to sort of flag up something that the Health Education England is up to, which is the work practice educators. They used to just do it for nurses. Now they're doing it across the board, either across trusts or in an area to, they've appointed these people, my colleague is one of them, to actually look at the training that is going on in the labs. Obviously, post-COVID, there's been an awful lot of interest in training of scientists, and you know, some of the things they're doing is actually trying to get some funding in so that we can backfill some training leads, so they can do some of their competencies and things like that. So, you know, across the country, it's obviously become flagged up, this sort of training problem. One of my main parts of my job is actually to get graduates through to registration, because that's another very big thing that's hitting the NHS trusts in particular. You know, we can spend a bit of funding and push that through in a sort of more private area. We're not totally private, but you know, to actually get people trained, and once they're trained, then to actually find the band 5 post for them. So there's that whole issue of a lot of graduates coming out and then can't find a job, or can't get trained, and they can't get into the first early stages. So, you know, these work practice educators are taking that all back to Health Education England for them to actually try and put some things into place. And I'm not quite sure where they'll go with it, but it is a good positive measure, really, because it is nationwide, this problem. And I just sort of saying, you're looking at your training and your transfusion. It's not just transfusion. It's every department is struggling to get those experienced scientists. So I'm quite hopeful that this might actually change the culture. You know, maybe the NHS needs to start paying for some training positions to get people trained, and you know, having them supernumerary to the complement of normal staff. So hopefully that will make a difference. So I'm just sort of flagging that up because you're talking about training, you know. But obviously that is one of the major issues with everybody, is to get a graduate through to a band 6 level. You know, is that process is quite labour intensive, you know, and I think that's having a big impact on all our labs. And obviously blood transfusion, the level of training is much higher. So again, you just not got people trained to do the job properly. Yeah.
That's a great point, Philippa. Those practice Health Education England practice officers. I would, if you are managing a transfusion lab or another laboratory in pathology disciplines, I would make connections with whoever your person is. So they're coming in now. They could be very useful to you in the future. So find those people and start networking with them now.
Really good. So has anybody got any final questions or points for discussion before we look at closing the meeting? Lots of comments coming through, Kerry, just to say thank you and just expressing how interesting this chat has been. But just give maybe a couple more minutes for any last questions, and then we may look at closing this meeting for this month.
And I'd just like to say thank you as well for all your participation and discussion. It's really good to actually be able to discuss some of these things. So thank you to everyone on the call.
Okay,
Thank you, everyone. Bye-bye.
Thank you, Martin. So just as we give a couple of seconds for any questions to come through, just some closing remarks. We do have a feedback form, as Selma mentioned. If you do complete, we do ask that you complete that, because that really does help us drive the topics and the direction that we take this group in. And it also gives us the means of sending you a certificate of attendance. So please do complete that as soon as you can. Like Selma said, we will get certificates sent out as soon as we can. There's a link coming into the chat box now. You can see it there from Selma. That will take you straight to the feedback form. It should only take a couple of seconds. And lots of comments coming through, Kerry, just to say thank you. Really interesting session. So I think on that note, we will bring the meeting to an end. Thank you very much, Kerry, for joining us today. Really interesting chat, and I think we're all looking forward now to for the new recommendations being published in the near future. As always, if you do have any questions that weren't answered, or you go away and you have a think about today's session and come up with a question, do get in touch. I'm sure Kerry won't mind picking up some questions after the session as well, so you can send them to us by email and we'll pick them up. And just to thank you again for joining us. Really good attendance today. And just as I touched on briefly, discussing with Martin, we'll be meeting again the last Wednesday of Feb. We'll be joined by Julie Staves, who's another really experienced transfusion professional, and we'll be looking at advances in IT and the implications for blood transfusion. So thanks again for joining us, and we look forward to seeing you next month. Thank you very much.